So hello and good afternoon to everybody. Today's session will be on communication techniques in palliative care. And before we start, I'll just introduce myself. So my name is Kathryn. I'm a palliative care specialist from the UK. And I've been working these last few years with Médecins Sans Frontières, Doctors Without Borders. And before that, I was working for a few years in Amman in the Middle East, in Jordan, as a palliative care specialist. And I'm very happy to join you today and to be facilitating this session. So just before we start today's session, just a couple of housekeeping points before we start. So if your connection is bad, try turning your video off. Otherwise, please feel free to keep your video running. That way it's a bit more of an interactive session. If you're not speaking, please keep your microphone on mute so that it doesn't disturb the presenter or the case presentation. And please, if you have any questions, do write them in the chat. We have faculty who are monitoring the chat, and we will answer your questions as we go through. We will have time during this session to have questions and some discussion, both after the presentation today, but also after the case presentation as well. So this session will follow the same order as the last session, in that we will have the case, we'll have a presentation of today's topic, we'll have some time for discussion, and then we'll have a case presentation based on today's topic, and then more time for discussion and questions too. So please do be interactive. Please do ask your questions either in the chat or after each of the presentations. And yeah, we're really looking forward to today's session. So our presenter today is Gladys, and I believe Gladys is now on the call. Gladys is a senior palliative care nurse working at Kenyatta National Hospital in the palliative care unit. And I believe Gladys gave the same session during the course, during the first course. So very happy to hear the session again, Gladys. So welcome back. And hopefully we can hand over to you now, Gladys. And please do introduce yourself if there's some more to say than the way I've introduced you.
Thank you, Kathleen. Good afternoon, good morning to every one of you. I think the introduction was elaborate. I'm Gladys, and I'm going to straight away share my slides.
Looks great, Gladys. I think you just by accident got muted. Yeah, perfect. And if you just put it in the full screen.
Okay, you cannot see my screen. I'm going to start with the topic, which is a communication technique in palliative care. And today's objective for this, just a minute. The learning objective for this topic is we need to understand the concept and components of effective communication in palliative care. And we also we need to understand the communication difficulties, because sometimes it is not easy. We also need to learn communication techniques to help in difficulties. When we are faced with the communication difficulties, how do we navigate through that? And we need to be aware of the barriers in communications with patients in palliative care. In my introduction, I want to inform you that effective communication is a core clinical skill. It's not an option. There are things which are popping in my screen, sorry.
Gladys, can you put it on full screen mode? If you just press the PowerPoint with the, not yet, if you press the icon in the top left with the triangle for play, it should just go into slideshow mode. This one.
On my side, it is full. Is it full on your side?
No, we see the slides down the left side, so it's not in. Yeah, okay, just try loading it up again. It might just need to be reshared. So we're still seeing the same screen, Gladys. If you've tried the screen mode and it's not working, perhaps we just need to continue with it like this.
What it wanted to do has now been achieved in the West.
Yeah, you should see wider than 12 months ago. You should.
Sorry.
Is it okay now?
It's not in presenting screen, but if you've tried, just continue like this, because I don't want you to lose time.
I think there is a problem because on my side it's showing full screen. Yeah. Can I go on like that?
Do go on, Gladys. Yeah, go on.
Thank you very much. I was doing my introduction. So truth is one of the most powerful therapeutic agents in communication, but we still need to develop a proper understanding of its clinical pharmacology and to recognize its optimum timing and dosage. It is not always every time you need to tell everything, or it is not every time you need to tell everything at the same time. So you need to gauge, when do I say and when, at how much do I say? So communication of painful truth does not equal to distraction of hope. Sometimes we fear when we are talking the truth, or when we are becoming honest, we are fearing we are breaking patients' hope, but that is not the case. So the goals of communication.
But as I just shared my screen because we weren't seeing you change the slide. So if you're comfortable with that, do you mind if we go ahead?
Yes, please.
Okay.
Thank you.
So just let me know when you want me to switch the slide.
Is it okay I continue?
Yeah.
Yeah.
Okay, next slide. I had talked about the introduction. Next slide, Irene. Next. Okay. So the goals of communication it's to share information. We need to share information with our patients to reduce uncertainty, because when some patients are very anxious, they don't know what they are dealing with, they don't know how much they are going to spend in their treatment, and also to build trust between the patient and the caregiver, and explore patients' worries and help patients make decisions about their care and their treatment, and also to improve patients' satisfaction with care. Next, please. So I want to bring to our attention the basic theories in communication, and these are very basic to not just to patients, but to everyone. When you meet somebody new, you need to introduce yourself. And sometimes we forget even to tell our patients, my name is so and so. So as you know, in palliative care, we deal with patients who are very frail, who are very sick, who may be forgetting very easily. So even if you introduce yourself previously, it is important for you to introduce again and remind them, we met yesterday and I told you my name is so and so. Address the patients by their names, because sometimes we forget and then we call patients by their disease. Establish who the other persons are. When they come in, a patient comes, a lady comes accompanied by the husband. We always assume this is a couple and we start addressing the patient like your husband said, your husband said. Establish what they already know. Sometimes they don't know. Sometimes they are in denial. So it is important for us to know, do they know what they are dealing with? And then we need to use simple language and avoid jargons. As much as we are medics, some words we use, they frighten patients. Like when they come and we talk these big names, it really frightens patients. And also you need to think of how you look. Are you looking frightened? Are you looking with a lot of fear? And then we need to know our boundaries and be professional. Next slide. So qualities of a good communicator. You need to be knowledgeable. You need to know the facts even before you go to the patient. Clear with information, as in when you are communicating, you need to be very clear. You need to give out the information in a with a lot of clarity, and then reassure the patient about confidentiality. Patients also, remember, they are human, and when they are coming to you, they are coming to you so that they can talk out their issues, not just because or issues are concerning their disease, even their private life. Sincere and non-judgmental. Don't judge patients by the way they look, by the way they are presenting, and then you need to be sensitive with the patient and empathetic. And this is one of the tools which patients, which we are not able to practice, empathetic. Are we able to go to the world? Is somebody talking? Are we able to go to the world of the client, of the patient, and help them? And then we need to listen, and not just listening, we need to be listening actively. And then we are able to pick the non-verbal cues. Next. So I usually use 6 key points in our toolkit. These are like my toolbox. When I go to communicate, you need to pick one of these tools one by one. One of them is comfort. As you take care of the patient, as you talk to them, are they comfortable? Just a simple question like, are you comfortable? You go to talk to this old man, like 70 years old, and he's naked in a bed or hospital bed, and they are in a pool of urine. Have you established whether they are comfortable? Question style. The more open the question, the more information you are likely to get. Don't ask questions, yes, no answers. Questions should be referenced with phrases like, please, may I know, or could you kindly share with me? And the patient is going to tell you a lot of information about themselves. Next. Language is the other tool which you need. We need to use the language which is understandable by the patient. If they are not able to understand our local language, can you look for somebody who can speak that language? Then reflection, pick up the key words as you talk to the patient. Pick up the key words associated with their feelings. If you talk to the patient and all of a sudden the patient starts being angry, you say this, or you say, pick those words, and by the end of the session, you need to say, when we were talking, I heard you shout, I heard you do this and that. Then you address that. Then summarizing. This is a fantastic tool. If you feel stuck in a consultation or in a communication sitting, you take this and then you summarize. You tell the patient, for example, sometimes you talk to a patient and they throw a question on your face and you are not prepared for that. You can pick this tool where you are going to reflect back or to summarize what you have been talking. I heard you say when you started this treatment, it has been like this, then you come back to the track. This is a fantastic tool. Next. The other tool is listening, and I said listening actively, including silence. Even if they decide not to speak, they are still saying something. Remember, when you tell them they have this disease, for example, they have cancer, somebody can go blank and they are still communicating within themselves. How can this be? And they are asking themselves questions. So do not interrupt. Be empathetic. Continue being there for them because they are still, it is a communication skill. Next, please. I want to introduce to you the 80-20 rule in communication, where we need to communicate 80% of the consultation time. You listen to the patient and you talk 20%, patient to talk 80%. But again, this has shown internationally that it is vice versa. It is the patient, it is us who talk more than the patients. You ask a patient a question and before they even answer, you are throwing another question. So let us learn to listen to the patients. Next. The other one is verbal and non-verbal communication. Remember, studies show that 7% of the message is verbally communicated by words. 93%, 93 is a very big percentage, is non-verbal. So as we talk to them, are we paying attention to the non-verbals or we are just following what they are saying? And then remember, they are also looking at your non-verbals. And the 93, 38 is vocal tones, 55 is vocal expression. And posture, gestures. As you talk to them, the way you are throwing hands, the way you are shouting. So be alert about non-verbal communication as you speak to your patients. Next, please. This is just demonstrating what I've just said. Next. Again, this is also demonstrating that lesson from Albert's research, because that was a research which was done and it showed those percentages, is that we need to pay attention to for more than just the words. We don't just sit there to listen. We sit there to observe what the patients are, how the patients are presenting themselves. Next. So what are the difficulties? Because we've said we need to know how to handle the difficult questions or the difficult communication techniques. Some of the difficulties we face in palliative care in communication is breaking bad news. I want to believe each one of you who is here can attest to me that breaking bad news is not an easy task. And that is one of the difficulties. The other one is difficult questions. When you are talking to the patient and all of a sudden they throw a question to you, am I going to die? It is not easy to say yes or no, or you don't know what to say. And the other one is denial. Most of our patients we take care in palliative care, and especially with cancer world, is denial. And it is a valid coping mechanism for those who are not able to accept or to come into terms. So it is a normal process. Next, please. So denial, as I said, it is a normal coping mechanism. It's like a wall, a stone wall, which is very strong. Don't try to take a hammer and start hitting that wall. It will come down, the whole of it. But try to look for a small window where you can see through. So try to talk the patient, try to encourage the patient. One time, the patient, you will see a small window where you are going to start now entering the patient. Next. The other difficulty is emotional reactions. Some of us, we are not comfortable seeing patients cry or showing emotions, and especially adults. We feel we are carried away by the emotions sometimes. Other times we feel like, why are they crying? You know, like here in Kenya, where we come from, people mourn differently. So when you see people throwing themselves on the floor, you are wondering, what is all this? So are we comfortable with that? Next. So the other one is called collusion, and generally it is an act of love and care. Collusion is when a person comes maybe the relatives of a patient come to you when the patient is outside and they are telling you, Daktari, when my patient comes in, please don't tell my mother she has the cancer. We know our mother, when you tell her she's going to die. But are you trained to cheat? Because you are not going to say she has malaria. So ethical principles can guide you how to handle this. And the ethical considerations are respect for autonomy. Does your mommy want to know? If she comes in and she asks me, doctor, what am I suffering from? I'll tell her what she's suffering from, because that is our autonomy to know. Beneficence, would it help mommy to know her diagnosis? When she knows, is it going to be beneficial to her? Of course, yes. Non-maleficence, would it harm mommy to know her diagnosis? What is the worst can happen if she knows her diagnosis? So you need to be professional, as I said before, so that you can help that family who is preventing their mother or their kin not to know the truth. Next. So I want to just highlight briefly about breaking bad news. Next. Breaking bad news is one of the key difficulties in communication. And what is bad news? Bad news is any information that drastically or negatively alters the patient's view of his future. When news are broken badly to you, your future will never be the same again. I see patients who are diagnosed with cancer 10 years ago, and when they come to me, you ask them, what is the worst part of your cancer journey? And the way the news was broken to me, I'll never forget. Next. So who is responsible? Because sometimes when patients come, you are feeling like you are dodging, you are telling them, wait for the doctor, wait for the counselor, wait for the social worker. But any healthcare worker can break bad news. As long as you feel competent and comfortable with it, you can break the bad news. Next. So we use the SPIKE protocol, which is in 2000, Walter Bell and colleagues set up a 6-step protocol for breaking bad news using the acronym SPIKE. And the SPIKE is S is setting, P is perception, I is invitation, then knowledge, emotions, and summary. Next, please. So the setting up, it is setting up the session, just being ready. Are you set for the task yourself? Read, at least read and know the condition you are going to deal with. Have you dealt with your own issues? You could be mourning your sister who passed on two months ago. Finish up with the pressing work, like at your place of work. Don't just put the phone there and everyone is calling you. Then environment, set the environment, arrange for privacy, adequate space, well ventilated. Next. Involve significant others. Sometimes it is not good for you to break bad news to somebody who is alone. Sometimes they need that support. It is helpful to start with a question like, how are you feeling today? So that they don't look like it is something very serious. That one, to indicate the patient that the conversation will be a two-way. I'm not going to you are not going to listen to me like I am going to give a lecture. So be aware of the nonverbal communication, yours and for the patient as well. Next. So the perception is finding out how much the patient knows. Do they know they have this condition? How much have you been told? Before you ask. It is important to gauge the patient's understanding of their situation. Just giving a question like, would you kindly share with me or what you've been told by your doctor about your condition, Mr. P? This helps the patient now you will start getting where she is or where he is, whether the patient is in denial or the patient does not know completely. Next, please. Then invitation, obtaining patient's invitation. How much information is the patient willing to know? Do you know, I have listened to you, but do you want to know? Yes, I want to know. How much do you want to know? Everything. Some patients say, I want to know everything. It is my condition. Others would say, maybe you talk to my sons. I just want to be treated. For instance, you can say some patients want to cover every medical details, but other patients want only the big picture. What would you prefer yourself, Mr. P? This establishes that there is no right answer. There is no right way. If you say you don't want to know, it is okay. And that is different for every patient. Next, please. So the knowledge is now where you are going to share the information. After giving the information, you have listened to the patient, now pause, assess whether the patient is ready, then present the information. Always give a warning shot. And remember, sometimes you might be feeling you are giving bad news, and probably it could be taken like a good news. For example, somebody who has been going hospital to hospital looking for what is ailing him or her, and then all of a sudden it's like, the disease is not, this hospital is not getting my disease. Sometimes it is a relief. So don't be frightened so much, even when they are not taking it so serious after you broke the news. Sometimes it was good news to them, because at least I know what I'm suffering from. I can start now treatment. So after giving a warning shot, and what is a warning shot? A warning shot is a statement where you can let the patient, it gives a patient a preparation that something more is likely to happen. I'm about to get bad news. So something like, present bad news in small chunks and stop in between to check that they are understanding. For example, if you want to give bad news of a report, you can tell the patient, your report has come back at it and it is not good. That is a warning shot. And the patient will tell you, check back. Are they ready to receive now the real news? Because you've just said it is not good. Don't leave it at there. Yet it's not good. You have this lung cancer. Pause. Check how they are faring on. How are they feeling? How are they taking the information? Then you continue considering on how they are taking it. Next. Use proper words. If you have given the warning shot, now give the information the proper words. Don't say, according to your X-ray, I can see some spots. No, it is cancer. It is not carcinoma. Patients might not understand these jargons. Patients might not know what are these hepatocellular carcinoma. Repeat the information. Do not overburden the patient with a lot of information. Avoid telling the patient, the disease has progressed, there is nothing we can do. There is a lot we can do, and especially in palliative care. Even if the disease has advanced for curative treatment, patients should be assured that support will be provided to improve their quality of life. Next, please. The other step is emotions and empathy. Respond to their feelings, because now you have told them and they could be feeling so upset, they could be feeling so anxious. So respond to their emotions. If you don't understand patients' reactions, you will leave a lot of unfinished businesses and you will miss an opportunity to be a caring expert. And I want to repeat that. You will miss an opportunity to be a caring expert. I want to say that there is no best way of giving bad news. The most important thing is how you support after giving the information. There is no baptism of cancer. There is no baptism of telling me your husband is dead. The most important thing is how you support. So stop talking with when they are showing strong emotions. Don't keep on telling them God knows, it is well. It is not well. Let them cry, just be there to support. Let them throw their anger. Allow silence to take place. Pause, observe and identify the reasons why they are reacting the way they are, and then address them later. Next, please. Then phases of emotions range from denial. Some will be saying, no, it can't happen. It is not me. Anger, sadness, self-pity. You mean I cannot have cancer? Dependency and hopelessness. Explore and respond to the patient's emotion. Give patient uninterrupted time to express his emotions and let him know that you are connecting the reason why they are behaving the way they are behaving. Next. Remember, you are not responsible for their emotions. Sometimes we go there and say, yeah, I'm sorry. You should not be sorry. You are not responsible. You are a messenger. You are just passing an information. But take care of yourself, ensure safety, take a deep breath and allow anger to wash over you. It will stop. Silence is okay. Use communication enhancers as they talk, just say, don't interrupt, just support. And don't argue. Next slide. Listen actively. Once the anger is dissipated, consciously respond by reflecting back to what you heard about major parts of anger. They will be saying, now this man brought me this and this or this. Then you will now know where you are going to put emphasis when they have settled. Next, please. S is strategy and summarizing, plan and follow through. Find out if the patient is ready for further discussion. Remember, you've just told the patient very bad news. That is not what they expected today. So don't start saying, now we are going to plan for treatment, we are going to plan for chemotherapy. They will not hear anything. Studies show that once you break the bad news, from there they don't hear anything. But find out, do they know, do they want to know anything further? If they want to discuss the next step, it is okay. Outline a step-by-step immediate and long-term plan. Immediate is, how are they going home? You've just broken them. It is like their world has come to an end. How are they going home? And then the long term, you will come back, we discuss about your treatment. Explain and contract about the next step. Should the patient have an unrealistic expectation, it may be useful to ask him to summarize what you have discussed. This will heal their emotions. Next. Offer your recommendations. I would say you don't need to go alone. Can I call your husband? Can I call your brother? Help patients to identify support network like family, friends, pastor. Ask if there are any questions or concerns before they leave. Arrange for an appointment, a follow-up. Document what you've discussed in the file. Next, please. Yeah, that is the spikes. And now I want to talk a bit about communicating effectively with the children. Children is a special group. And when you are communicating to them, there are some issues you need to put in consideration. One of them is their age. How are they able to communicate? Some children communicate by drawing. You tell a child, can you draw how you are feeling? And you will see them drawing a face which is very sad. Or can you draw your mother? And you see the way they are drawing, the mother is like shaded. And when you ask them, what does this one mean? It's just not there. So children, depending on their age, development or stages, communicate differently. So you have to consider that. Unlike teenagers and young adults, they are very easy to communicate with. Only that you need to be very knowledgeable because they want to know everything. Remember, they have gone into the world of Google and they have Googled all these things. You are going there thinking you are going to talk about this disease and they have already read everything and they know everything. So you have to know, which group am I talking to? Is it a 3-year-old? Is it a 6-year-old or a 10-year-old? Next. So the drawing is very effective even to the you can see like this picture, the way the doctor is showing the mother and is emphasizing. If the child is not able to communicate, you can communicate through the relative, through the mother, or through the significant others. Next. So there are some barriers to communication. I want to imagine if this was a physical class, everyone would say different things, because I know very well we don't communicate very well and we need to improve. But some of the barriers are physical barriers, staff shortage. You go to our hospitals, especially public hospitals, and you are like, people are not even talking to patients. You are throwing words, background noise. The place is so noisy with so many things happening. Poor lighting. Remember, if there is no lighting, you cannot see me and you cannot even read my non-verbals. And poor signage. You send a patient to the lab and you don't know where it is. You are saying, you see that corner, after there, you go this way. That is poor communication. The other barrier is system design, structures which are unclear. You tell a patient, you see that building tall there, that is where we are going. And then there are so many tall buildings. Lack of clarity in roles. You want to talk to a patient, you are telling her to go to the next room where there is a doctor, and you know, in the hospital, every man on a white lab coat is a doctor. All these things, they bring a lot of non-effectiveness in communication. Attitude barrier, lack of motivation. Staffs are overworked. You don't even feel like talking to, leave alone patients, even to amongst yourself. Resistant to change. Even if there was a staff shortage is not there, you are not ready to change. You are told, I want you people to be greeting patients when they come in the morning and when you introduce yourself, but you just see yourself, you are not doing that. Ubiquity of words. Words sounding the same but different meaning. When you are communicating, are you clear? Are you talking about this, or you are talking about the other? Next. Patient barriers, some of the patient barriers are cultural beliefs, like patients who come, you are trying to talk to them about this issue, but they are blocked because according to their culture, you cannot continue talking about these topics in front of everyone. According to our culture, an old man cannot talk to these young doctors who are only 24 years, like openly. So you see now communication is not taking place and the patient is not going to be treated properly because he cannot open up to that young doctor. Not aware of their right to information. Patients, they don't know they are supposed to ask for information. So they are just treated and then you are told, go to the lab. They have not asked any question. Physiological barriers. Individuals, personal discomfort due to ill health. Remember, this is a patient has so many comorbidities, so it is not able. He is not able to communicate because he's weak. Some have disease in their mouth. They are not able to communicate. Poor health or poor vision because some are old, and the more they go, they are old, the more the vision is deteriorating. Hearing and speech difficulties. Presentation of information presented by clinicians who lack skills. You are treating patients like you are treating objects. Presented too complex. The information is too complex, as I said, about the jargons. You are told, you know, now this is cancer, and you know it is non-differentiated, and you want to look like you are very much learned. Next. So communication during COVID-19, I think it was very hard for us, all of us, I want to believe, because now you are masked, you are gowned, you have gloves, sometimes even touch is a communication skill. But there was no touching. There was no coming closer to one another. Remember, there was that 1.5 meters apart. So it was not easy, and it was not effective as well. Next. So good communication is good healthcare. There is no healthcare without communication. There is no quality healthcare without communication. So we need to change our communication skills so that we can take care of our patients well. Next. And that is the end of my presentation. Thank you very much.
Thank you so much, Gladys. That was really, I found that a really rich session with so much information. You know, we went from the very simple communication techniques, like remember to reintroduce yourself because our patients are sick, and asking simple questions such as, are you comfortable before starting the consultation, to skills like listening and empathy, and then some more complex communication tests like breaking bad news and how to cope with denial. So much in there. Thank you so much. And I'm going to encourage the participants that, you know, if this is an area of that you want to improve your skills, and for most of us, we do need to keep improving communication skills, then please do watch the recording, because I'm sure with so much information in there, there will be more things that you can get if you watch that a second or third time. That was a super session. Thank you. Thank you so much, Gladys. If anyone has any questions, can you please write either your question in the chat or raise your hand if you want to ask a question. And just while we're waiting to see if any questions come in, I'll see if any of the other faculty want to add any comments to the end of Gladys's presentation, whether that's around any cultural adaptations that might be needed for communication in the region. And I know we have people on the call from other countries too. So it's sometimes interesting to think about how do we need to adapt our communication to match the culture, or how do we need to be at least aware of the differences in culture so that when we are communicating, we're aware of those barriers that Gladys quite rightly pointed out. Yeah, please go ahead.
I'm one of the students, and really I attend my regular lessons and classes, but the problem I'm facing is that I cannot go to the group when you have sent it for me a link to join the group. Whenever I try to go to the link, it's showing me to saying that you cannot go without allowance with group admin, something like that. I'm facing that challenge.
Abdi, I can privately message you, Abdi, and you can stay on the Zoom call at the end, and I'll sort it out for you.
Sorry?
Thanks a lot. I'll figure it out with you if you can stay on at the end of our call. We still have about half an hour left, so we will sort you out. Thanks, Abdi.
Yeah, I have.
Okay, so thanks, Abdi. That we'll deal with that on the side. So just coming back to the communication session, we've got a really nice question here from Lamek, and I wonder if I can put it to you, Gladys. So the question is, as a professional, can you communicate with a patient even if their culture doesn't allow such information? So it's a really good question. It's one that comes up a lot. Gladys, do you want to answer that?
Yeah, I've seen that question. Thank you for that question. Cultural issues are very tricky, but as well, we need to respect people's culture. If a patient comes in and says, I don't want to be seen by a lady, am I going to force myself to that patient? No. I try to look for somebody who is preference to the patient. If there is a male nurse or a male doctor who can see that patient, I would prefer that, because the patient came to be treated and did not come to go home feeling offended. So I wouldn't wish to force myself into their culture. However, it is good to give information. For example, if a patient says he comes in a lot of pain and they say according to their culture, they don't take medication for pain, it is important to give information. Then the patient plus their family can also help them understand this is going to relieve your suffering and it is going to improve your quality of your life. I don't know.
Thanks, Gladys. And I think there's There's another question here around who do you give the information to? Should you give it to the patient or caregiver? And I think one thing that I just want to add on the back of Gladys's comments is that, you know, we need to be mindful of a culture. Okay, so some places where we work, it may be very normal that the family will receive information rather than the patient. Okay, so we need to be aware of this in the culture that we're working in. Having said that, it doesn't necessarily mean that a person is following the cultural norm within their country. Okay, so you will always have people who want information, even if they're not usually in their culture the ones who would receive it. And similarly, you'll have cultures where people, you normally would talk to patients about information, but they don't want the information themselves. They want it to go to the family. And actually, the only way we know is asking. So we need to ask, you know. So if we need to give information, will we give the information to you, or would you like to speak to the family? And it's the only way we know how a person wants to receive that information. Okay? So when we're not sure, we just ask. And I can see a raised hand here. Colleen, do you want to add something? Do you want to add something there? Please go ahead.
Yes. Thank you so much, Kathryn. I just want to add on the question about culture. So in palliative care, we advise to have an open door policy, because, for example, you can get someone who has a different remedy. You give them the news, and maybe there's a plan, and they say, for example, that I need to go back to my ancestors. I need to go back and take some herbs first, or go and talk to some spiritual leaders. So as a palliative care, as much as you may think it's not the right thing, you don't say, no, don't go there. You just say, okay, that is what you feel like, but according to us, this is our plan. So you leave it open, and they can decide to go and come back. And when they come back, we don't judge them and say, why did you go there and come back? So just being open to people's culture, you explain to them what we do, but don't necessarily judge what they think or what their culture is. So we just give information and keep an open door. Thank you.
Thanks so much. I think that's a really good point to highlight, Magdalene. Thank you. There's lots of really good questions coming in. There's one about if a patient is suicidal, okay, and if someone is suicidal, do you then give them bad news? Okay, and I think this is a special circumstance. And actually, if you believe that bad news can cause serious psychological harm, okay, which is unusual, bad news can cause people to be upset, and that is normal. But if you think that someone is suicidal and hearing news may cause them to suicide, then this will be a special circumstance where you may make a decision as a team not to speak to that person at the moment. Okay, so that's a special circumstance. There's some.
I think when you are doing the spike protocol, where I say you need to assess and reassess, is the patient ready? So it is upon you to check, even if the patient was suicidal, do you need to break bad news to such a patient? So you have to have very good assessment skill so that you don't break the patient more.
Thank you, Gladys. Thank you. And there's some more really good questions, and I'm really just aware of time. Perhaps we'll just answer a couple more questions here. There's a question about denial. Gladys, can you just elaborate on? Joseph, do you have a question? If you can just hold your question, Joseph, for a moment, and we can come back to you. There's a question about denial, Gladys, around how can we deal with patients in denial? And I know you touched on this in the session. Do you want to say a little bit more about how you cope when patients are in denial?
Yeah, patients in denial, as I said, denial is a coping mechanism. It is not that people want to deny about their condition, but that is a normal reaction according to how you receive news, bad news. So the first thing you deny, and it is because you are not able, you cannot contain that information. And that is why you see people say, oh no, it can't be. Just like you can hear your relative, your very close person has died. And the first thing is to say no, because you cannot cope with that. So denial is a coping mechanism, and it is important for you to affirm that whatever they are going through is very normal. It is not that. It is not that they are going away. So it is real. So try to continue supporting that person and try to continue encourage them. They will overcome it one time. And that is why I said it is like a wall. So as you talk to them every time, you will try to see whether there is a window where you can enter, but don't force them to accept what is not, what they are feeling it is not real. You tell me I have cancer, I will say, oh no, I can't believe this. So try to support me. One day you will hear me say, I will go for that chemotherapy. And I'm now starting to accept. And then you will ask me, oh, what is that? That is the treatment for cancer. And then you will start knowing, I am now starting to accept. So don't force them. It is a normal reaction, and support them in that. So long as it's not affecting them negatively, because some people deny and they go away. Some people deny and they continue with the treatment, which is a very good thing. But one time they will accept, and then they will be able to say, oh, when I was told, I could not believe it. Yeah.
Thanks, Gladys. So denial is a part of the grief response, as Gladys said, and actually people sometimes just need that time. Okay, so they've heard, and they're using denial to cope. So thanks, Gladys. That's helpful. And what we'll actually do, there's some really good questions, and what we'll do, we'll ask the faculty to answer the questions, and we'll share the answers to those questions after the session, because I don't think we're going to have time to address all of them, because now we're going to move on to the case presentation. And today we've got Dr. Marianne, who's going to present the case. Dr. Marianne is a senior consultant for pediatrics and adolescents in oncology and palliative care, and based in Australia, and has quite extensive experience of working in humanitarian settings in Southeast Asia. Dr. Marianne, I hand over to you, and please do feel free to reintroduce yourself if there's more you want to share. Thank you.
Thank you. I'm just trying to figure out how to share the screen, which is always a challenge. So I did send it through to Erin, just in case. I'm not too sure.
I can
whether...
do it from my side.
Can you do it from your side? Because I'm just too hopeless.
Yeah.
Thank you.
No problem.
Thanks, Erin. Thank you. So I guess I'm going to use the wealth of knowledge that Gladys has already provided in her overview of communication techniques to demonstrate how to communicate bad news within the pediatric oncology setting with one patient example. Thanks, Erin. And the main things that one wants to get out of this relatively short presentation is how to communicate with parents when a child relapses from their disease, and not only that, but also how to address some of the child's concerns when the child actually doesn't really understand what's wrong with them and nor what's going to happen to them. They just have an awareness of things that are happening around them. Thank you. Thanks, Erin. So the example is a 6-year-old girl who'd had enucleation, that's a removal of one of her eyes, the right eye, several months previously at another hospital. It was unclear exactly what had been done, other than that the eye had been removed, and the family reported that that was for an eye swelling. They'd been told that they needed to have chemotherapy as follow-up for the child, but they couldn't afford to move from where they were located to a capital city. They couldn't afford to move to go and get treatment. And so now the child's presenting to the emergency department with evidence of progression in the right orbit. There's some abdominal swelling, and the child's really very malnourished. She's got limited mouth opening with foul breath and difficulty swallowing. And the diagnosis is thought to be either a retinoblastoma with widely metastatic deposits, or a neuroblastoma, that the orbital disease had actually been a secondary, or perhaps it was a melanoma of the eye, which has now metastasized to the liver, or perhaps even a rhabdomyosarcoma of the eye, which has now moved on and metastasized to the liver and other intra-abdominal organs. Thank you, Erin. But regardless, the child is clearly very unwell with very significant disease progression. She has her mum and her dad with her, The father is a farmer, the mother is a housewife. Father has 2 older children, both daughters. They're aged 18 and 12 years. They've had to sell their land and spend all the money to get to the hospital seeking for help. And they're a little shattered because when they've been seen in the previous hospital, the surgeon had initially told them that they felt that the child was cured. So they'd gone from having a child who'd had an eye taken out, surgeon says that the child's been cured. They were then told by other pediatricians at the hospital that chemotherapy was warranted. They couldn't afford it. They clung on to the hope that surgery was sufficient, went home, and then over a short period of time have a very unwell child that they bring to the ED. Thank you, Erin. This child, she had been in first grade at school, but then stopped going to school about a year ago after the original diagnosis. She's 6. She knows that she'd had a mass in the region of her eye, but she doesn't really know very much else about what's going on. She's very concerned, however, and very anxious and upset whenever her parents cry, and they're so upset that they're spending a lot of the time quite distressed and in tears. She can admit to feeling better when she plays with her friends, but of course she hasn't actually seen them much since she left school some time ago. Thank you. So from the palliative care point of view, it's clear that the child has got advanced metastatic recurrent cancer and there is no real chance of cure. And this needs to be provided to the family in a compassionate way. Thank you, Erin. So I'm asking you, the participants in this meeting, to think about how you're going to tell the parents the news. You need to think about the steps that you're going to take before seeing them, and prepare yourself, and then review the way that you might discuss the results with the parents and then their extended family if they ask you to. So I'd just like you to take just a couple of brief seconds, really, just to think about what you would do in this situation. Thank you, Erin. So in pediatrics, we use the spikes model that Gladys has already identified and talked to us about. So spikes, S for the setup, P for perception, I for invitation, K for knowledge, E for emotion, and S for summary. Thank you, Erin. And if we break this down a little bit, we're going to think about the setup. What are the important considerations when breaking bad news to this family? And what words would you plan to use? So again, just pausing for you to think about that. Thinking about the vocabulary that you would use, the information that you want to give, the need to find an appropriate physical space, your body language, and being calm, perhaps taking a breath before embarking on what the task is before you. Thank you, Erin. So as Gladys has explained, the important considerations, the setup, need to see the parents in a private room, in a quiet area. Trying to talk to them on the open ward, even in front of their child, is really not acceptable. Ideally, you would have the child looked after by other nursing staff or aides on the ward if possible, whilst you take the parents away to a quiet room so that they can focus on what they're being told without the distraction of their child and without the need to cover their emotions in front of them. It's useful to take somebody else with you, not only for their support, but also actually at times for your own support. It's also very important for that person to be there, to be able to follow on with the conversation after you've had it, to go over things again, to reiterate what has been said and re-explain. If you have access to a palliative care team, then it's very important for a member of that team to be included in the conversation so that they can hear what is being explained. You need to think about what words you're going to use. Perhaps to start off with the parents, what have the doctors told you about your child's condition? What do you understand about what is wrong with them? Thank you, Erin. Moving on from there, we move on to the next couple of sections of the spikes format, the invitational. So what words are you going to use? And what knowledge, what would you plan to say? Thank you, Erin. So what words would you plan to use with these parents who are distressed and are seeking an explanation for what's happening to their child and what can be done for it? What words would you use? You need to ask them if you are able to tell them more about what is happening. Do they want you to explain? Are they clear that they're going to hear the information from you? And then you would start by saying, unfortunately, I have some bad news, for instance, or the tumor in your daughter's eye has returned after the surgery. And moving forward into this is cancer and it cannot be fixed with any medicines. Thanks, Erin. But it's important within that to be empathic, to allow the emotions of parents to be at the forefront, to allow them to react in their own way, in their cultural way, in their own personality way, you know, in either in an open way or in a quiet and withdrawn way, without perhaps feeling threatened oneself. You need to be empathic to their understanding and to what they want to know and to what they're hearing. Thank you, Erin. And how do you acknowledge this? Acknowledging emotions is really done with empathy. Statements such as, I wish the situation was different, is very, very useful. The nurse model that was devised by Smith in 2002, name the emotion. I can see that you're feeling very angry, or I can see that you feel confused. Understand. I expect most people would feel that way in your situation. Respect for the people who are hearing the information. You've shown remarkable courage, both in seeking further help and traveling the distance and selling the property to come and look for help. The S is for support. So identifying that they will receive support. Giving bad news without removing hope is very important. So providing avenues of support provides hope to the family, but not inappropriate hope. And E is for explore. Tell me more about how you're feeling. What more do they need? What else can they be provided with? What are they feeling? Are they understanding what is being said to them? Thank you, Erin. That one summarizes the discussion. You check the overall understanding of what has been said during the conversation. Their understanding really is identified by the questions that they may have when they're asked if they have any questions. You review the plan for the next step. So as I've identified, maintaining hope, but realistic hope. So identifying what can be done, appropriate analgesia, appropriate comfort care, appropriate environment, trying to make sure that the child has the things that are important to her to make her feel comfortable. So providing hope for the family that the cares for the child will still be appropriately addressed. And then it's very important to document all of the discussions and the summaries to ensure there's clear communication to other members of the team of what has been discussed. And that then provides a stepping stone to move into discussions the next time around. And one can use that documentation to revise what's been said and summarize what has been said before embarking on the next conversation. Thank you, Erin. Okay, you've done it. So after the parents had been made aware about the prognosis for their child, that there was no curative option, They did indeed have very great difficulty in accepting that there was no more treatment that was available to cure the child's illness. And they required multiple counselling sessions with varying team members to try to facilitate their understanding. This requires patience, reiteration of the information on multiple occasions, seeming repetition of what has been said before, and re-explanation using different words to say the same thing over and over until the parents of the child are able to at least understand, even if it's still difficult for them to come to terms with what is actually happening. Thank you, Erin. But of course, talking with the parents is only really one side of the coin in pediatrics. There's also the need to communicate with the child. That doesn't necessarily mean that one has to communicate with them about what's going to happen, or the fact that they have a disease that is going to cause them to die. But it does mean that communicating with the child allows one to gain some understanding of their understanding, and for them to gain understanding of what's going on. And as Gladys identified, using drawings and toys with children can gain a huge amount of information. For instance, a child who was asked to draw their family, who drew the family, 3 children and the parents, and a family of 4 children, and then up in the clouds, a picture of another child. And she was able to explain to the psychologist that this was the family that she knew she was going to be looking down on. This wasn't this particular child, but provides an example for you as to what the sort of thing that I'm talking about. Or using toys to perhaps try to explain, using a teddy bear or a doll to try to place the child in a position that the child feels comfortable, asking the child to demonstrate on her toy where a site of pain is, or where she believes there is a problem in the body. And using these techniques, the team was able to gain some ability to communicate with the child and explain to her what was wrong with her in words that she was able to understand, including her understanding of why she needed to have blood transfusions at times, and why there was a need for injections and sometimes for pain medicines by mouth. Thank you, Erin. After a number of weeks, the parents were in acceptance after, as I've mentioned, repeated counselling sessions with various members of the team, and the palliative care were able to understand the child's concerns using art therapy and toys. The psychologist at one point did share with the parents that their crying made the child upset. She'd been able to draw this, the fact that she was upset whenever the parents were in tears. And so the parents chose to limit their child's exposure to their crying. Thank you, Erin. So I guess in summary, this last slide really allows you to think about what you've learned about communication skills in palliative care through Gladys's talk. Ideally, it would allow you to share an example of when communication with a palliative care patient didn't go well, and how that helped you learn to improve on future occasions, perhaps, and to share an example of what you hope to put into practice at work this week. Thanks, Erin. And so that's the final slide, just asking for any questions. Thank you.
Thank you very much, Dr. Marianne. I think that was extremely powerful, and actually putting that theory that we learned during Gladys's session into a real case. Really did drive those steps. I'll now just ask you to think over those points for discussion that Dr. Marianne invites us to think on. And if anyone wants to share a difficult communication scenario, or a communication scenario that went well, that you want to, if you want to unmute and share, I'll invite you to do that. Meanwhile, while you think about that, There is a question here, Dr. Marianne, that we'll put to you, if that's okay. And of course, I think it's what age of a child is it appropriate to, what would be an appropriate age to break the bad news to the child? An example, like they have a cancer diagnosis. I don't know if you can give us a bit more information on that, Dr. Marianne. Thank you.
I think breaking bad news to children is sort of reframed around more asking questions to the child, because their questions usually stem from their desire to have an answer. For instance, they may ask a parent, if they know they're very ill, am I going to die? And it would be very simplistic to say yes, but that may well not be actually what they're seeking. So I prefer to reframe their question into a, I wonder why you're asking me that. So that, why are you asking me? And sometimes it's because, oh, well, because I'd planned to see my friend tomorrow morning and I was just wondering. So then one can then talk more about that. It isn't always, the child will sometimes pick up on vocabulary that they've heard adults use and use it inappropriately. I think into teenagers, and one has to get to know one's patients, but into teenagers, it's much more difficult to pick out whether they really understand or they don't really understand. Around the age of 7, it's purported that children understand the meaning of death, but whether they understand their own viability and their own end of life or significant illness at the age of 7, I think is very, very questionable. Certainly teenagers are more likely to understand what cancer is and what terminal cancer is, because they've probably been exposed to it through other family members, or they've heard about it within the hospital setting. And even then, they often don't actually want direct answers to the question. So I often prefer to, I guess, answer their questions with question to try and pick out exactly what it is that they're trying to find out.
Thank you. That's really wise words. And I think answering a question with a question, really tells that person that you've heard their question and that you do want to answer it. But as Dr. Marianne has said, that they may be asking a question, but may not be seeking that particular answer. So that's really helpful for us to remember. Sometimes if you don't know what question to ask, you can simply say, I don't know if you agree with this, Dr. Marianne, that's a really good question. Thank you for asking. I'm just wondering what made you ask that question. So you can give yourself time to think on your feet, because it can be hard when these questions come if you're not prepared and you can't think of a question. So just saying that's a really good question and thank you.
And it always comes when you don't expect the question. I clearly have the opportunity to live in a country where a lot of people drive cars, and I say to parents that don't be surprised if when the child's sitting in the back seat of the car and you're driving the car, that is when you're going to be asked a difficult question, because they know that you can't look them in the face and they know that you're distracted slightly by something else, and it's always at those sorts of times that the child will choose to ask the most difficult question.
Yeah. So always be ready for, always be, we could be caught on the back foot at any time. Thank you. And there's another comment here about, and this is really echoing what Gladys was saying in the first lecture around, and this is from Richardson. I don't know if I've got your name right, I'm sorry, but this is around the 80%, 20% that Gladys talked about earlier, and how really we should be 80% listening. And actually that gives us a lot of information and that will guide us on what to say as well. So that's a really important point. So thank you. We've got probably a few more minutes and a few more minutes for any other questions. I recognise there are a few questions in the chat that we haven't answered. There was one around, and it's one that always comes up when we teach communication, and I just wonder whether we might address this in the last couple of minutes before the end of the session. There's one around how to cope if the family don't want you to give information to the patient, and the patient is asking for information. Let me just check I've got that Right, some way back in the chat.
Yeah, I think if Gladys is still on the call, I'd be interested to hear how she deals with that when you have families in the Kenyan context asking not to share information with their loved ones. Gladys, are you still there? She might not be on the call.
This is Makiline.
Oh, hey.
Yes, Gladys has she's dropped off. She's able to join.
Yeah.
And it's a technical question, which would be the best one to answer. But what I've learned from practice is that in Kenya, because of the culture, and we talked about the cultural considerations, sometimes the autonomy does not necessarily lie on the patient alone. So usually, most of the time, the medical person tries to negotiate or convince the relatives, because you find most of the time the person who is asking that maybe is the one who is paying or the one who's taking care of the patient, and then the one who has the power to make decisions for the patient. So there's usually a lot of negotiation with the caretaker on the benefit of breaking bad news, as well as and that it will be useful to break the news to the patient. But there's also some options where if the patient is sober and he has the right mind, then they just break the information. And then you find out with the relatives, why don't they want to share the information? Most of the time it's genuine concern, but other times it's because of some reasons which may not be beneficial to the patient. So I think the main thing is looking at the autonomy and looking at the capability of the patient to be able to handle that news. And then secondly, negotiating with the relatives, especially if the power of making decisions lies with the relatives.
Thank you, Makiline. I think that's really important, and I like the negotiation part, because actually having conflict with families is something we really want to avoid, and so it's about negotiation, it's about communicating. There's one helpful question that I sometimes find useful. If the family are really convinced they don't want to the person to have information while they want it, one thing that can be helpful is just to say, ask the person themselves. Okay, so you can say, how about if we ask the person what they already understand? Because often we know that patients know a lot more than we think they do, and the family might consent to that. They may say, okay, we can just ask the patient what they already know, and they might say to you that they already do know the information, and it just hadn't been communicated between the patient. I see a raised hand. We have TechnoSpark 2. So TechnoSpark 2, do you want to ask a question or make a comment? Please go ahead. You'll just need to unmute yourself. Okay. So we don't hear you. Please do write your question in the chat, and we'll get back to it. If not during the session, we've only got a couple of minutes. We can get back to any questions that were unanswered after the session. So
the other thing, Kathryn, I wanted to add to that is that the other way to help give a patient autonomy and also be very sensitive to cultures that are more communal in their decision making is to address the patient and to ask their permission of who they would want information to be given to. Sometimes we can talk to patients and families and just say I do believe people understand when they're having tests done. So you could start the conversation by saying some of the results of your tests have come back. In your family, what is the best way for me to share this information? Is it with your family, you? I know that that still may not fully be in agreement with some families, because I guess you're still giving some information that they may not even want their loved ones to know, that the test results are back or things like that. But that can also be one way to communicate with families that are, and still including the patient in the discussion.
Thanks, Erin. And we just have a last question before we close the session and give announcements. So very last one is when to share the information, if it should be immediately after diagnosis or when the disease is in the last stages. Evan, do you want to say something on that?
Yeah, I believe in all of our healthcare settings, regardless if it's an urban setting, a rural setting, in a refugee camp, or in a refugee community, internally displaced community. I think it's very important that when we have information as a healthcare team, and we believe that the information that we've received from pathology or the diagnostic team, we do come up with a plan of how we are going to disclose the information with the family and the patient. So I would say immediately after we have the information, we should be sharing that information, but making sure, like we talked about in the spikes model, the setup is very important. So if there is a day that's not going to work for all the family members, I believe it would be all right to wait a day or so. But if very important decisions need to be made related to treatment options or what protocol is chosen, I believe it needs to be relatively soon after and not waiting till the last stages.
Thank you, Evan. And I see we're really just in the last couple of minutes now of the session. So I want to thank the speakers for some really fantastic sessions today, for Gladys for a really rich session on the communication skills, and then for Dr. Marianne for putting those skills and that theory into practice with a really good case, pediatric case. Next week we have pain management and opioids. So that's next Tuesday's session. Evan, I'm just going to hand over to you. I don't know if there are any other course announcements you want to make before we close the session.
No, I think we're okay. I'm not sure what's happening with the WhatsApp group. I've tried to look online to see if we can have more members on. I think the best thing to do is to email me directly at the Palliative Care PC Humanitarian, and I'll add it in the chat again. And I will, I guess I'll have to directly add you to the WhatsApp group rather than using the link. Maybe the link isn't working properly. So for anyone that hasn't been able to join our WhatsApp group, it's a group for alumni as well as the current participants in batch 2. And we often communicate that way, but also by email. So yes, please make sure you sign into the attendance. We're trying to use Google Forms for our attendance just to easily track who's on the call. And again, I love it that we are inviting colleagues and wanting more people to know this information, but please just leave that Google Forms link just for those that attended this call today. And yes, I think we're good. If you have any further questions throughout the week, please don't hesitate. We're all around and we have a large group of faculty. We have about 15 faculty. So there's always someone to reach out to in your time zone that would be willing to support you in the work that you're doing. So thanks, everyone. Bye-bye.
Thank you. Thanks, everyone, for a great session.